Pelvic asymmetry is when the bones of the pelvis differ in alignment or shape between the sides. But whether this contributes to pain is a contentious topic in rehab science. Some consider it of central importance, while others simply ignore it, citing a lack of evidence. But that's not even the crazy part. Many who do assess asymmetry rely on one test and one test only, and that is the Ober's test. But how accurate is it? Can one test really tell us that much about pelvic asymmetry? Well, in this episode of Beyond the Barbell, we're going to dive deep into the Ober's test for measuring pelvic asymmetry. We'll talk about what it measures, whether it's reliable or valid, and we'll go through common testing errors. Now, by the end of the episode, you're going to know whether the claims made by those who use it actually hold up or not. So without further ado, let's go ahead and dive right in. All right, first little sip of this caffeinated Diet Coke here at 12:30 in the afternoon, because we're going to need it. All right, we're going to start off with a question. Why does this matter, right? Before we dive into the nitty-gritty of the test, we're going to address this question. What does it matter if the Ober's test is reliable and valid for measuring pelvic asymmetry? Why even ask this question in the first place? Well, there's a lot of angles I could take with the answer to this question, but I'm going to do my best to kind of keep this short so we can get on with the rest of the episode. And to answer this question, we have to start with an assumption, which is going to be as contentious as the test itself. And that assumption is that pelvic asymmetry correlates to pain and/or movement limitations. So if we can assume that there is a correlation, then an invalid or unreliable test means that any information we get from that test cannot guide treatment. This also means something else. It means that we should call into question any treatments that are based off the results of this single test. Now, in a few minutes, you're going to discover the hidden costs here and why this is so consequential. So with this all said, let's go ahead and cover what the test is, go through a brief history, and then summarize the current evidence. Then from there, we're going to talk about how some practitioners use this test, and then why we might want to reconsider that. And in doing so, we'll go through some of the common testing errors, and we'll have a really good time with this. All right, so what is the Ober's test? The Ober's test is a clinical test created by Frank Ober in the year 1937. And it's traditionally performed by orthopedic physicians and physical therapists. Now, the traditional purpose of the test is to test for shortness of the iliotibial band or TFL muscle. The TFL, or tensor fascia latae, who knows how to say it, attaches to the IT band, right here from the ASIS to the top of the IT band and through here. It's a more anteriorly situated muscle. And it can either pull the pelvis forward, internally rotate the leg, or abduct the leg, just based on its attachment sites. Now, to assess the shortness of the iliotibial band, or TFL, the tester is going to take the leg, they're going to abduct it, they're going to flex it, and then they're going to bring it back into extension. Then from here, keeping the pelvis stable, they'll attempt to lower it down to the table. And then depending on how far it gets down, it's going to be ruled subjectively a positive or negative test. An inability to adduct or move towards the table past this parallel position in the traditional description is going to be a negative test. But the inability, or the limb being maintained here above that horizontal line in abduction, would indicate a positive test reflecting an inability to adduct that leg. And the initial thought with this test when it was created was that the reason was because there's shortness in the TFL muscle or the IT band. But this assumption as to what the test actually tests has come under question in recent years. And the primary reason for this is a cadaver study from 2016. In this study, the authors found limitations in the ability to adduct even when the cadavers did not have IT bands and even when the cadavers did not have the TFL muscle. So if we have no TFL and if we have no IT band, but we can still adduct, this obviously casts doubt on the idea that this test tests for IT band or TFL muscle shortness. And from this, there's going to be two interpretations that emerge primarily. The first is going to be that other structures, like the gluteus medius and minimus muscles, which are kind of right here, as well as the joint capsule, which is obviously the most proximal to the hip joint, are actually what limits the ability to adduct. Now, another interpretation, in which we're going to go into in the rest of this video, is that the position and or alignment and or shape being asymmetric in the pelvis is actually what alters hip movement on this test. Now, this latter take is common among those who practice postural restoration, or as you might have heard it, PRI. Now, PRI practitioners assume that if this test is positive, that indicates a left AIC pattern, and we'll go into that in a second, and that if it's negative, they assume that that person is neutral. And again, we'll go into that in a second. Now, before we get into that, it's worth noting that the test in PRI land has been renamed, and they call it the adduction drop test. And I think, just as an aside here, I think this is a reasonable take, because if we say that this test is generally measuring the ability of the femur to adduct or move towards the midline relative to the pelvis, then we're not saying that it's necessarily due to a specific structure like the IT band or the TFL like we originally thought. But in a second, you're going to see why I disagree with what they assume is actually the cause of this limitation. Now, it's worth noting as well that the way PRI performs this test in the actual manual and when it's done correctly according to their procedure is pretty much the exact way that you see it in Kendall and Kendall, Posture and Pain, one of the most classic physical therapy texts. And that is except for one big difference. And we're going to talk about this big difference later in the video, and you're going to see why this is a very important point to understand. Now, again, their interpretation is going to be different. They believe that the reason you can't adduct the leg has to do with the triplanar position of the innominate bone relative to the sacrum. So in their view, a positive adductor drop is when the knee can't drop down and touch the table. And they will say that this reflects a forward hemipelvis, which they're also going to say is more common on the left. Now, they describe the reason of this position as being due to overactivity of muscles on the interior side of the body on the left, which they call the left AIC chain, anterior inferior chain. And the position at the pelvis is flexion, abduction, and external rotation when we're describing that movement from the perspective of the pelvic inlet. Okay, and we'll talk all about why this matters more in a second. Now, the proposed reason as to why this is more common on the left than the right is that people, according to PRI, tend to bear weight and favor their right side over their left. Okay? So in PRI, the purpose of their initial interventions on day one are to reposition this pelvis towards neutral. And the way that they're going to determine that is if they can go from a positive adduction drop test to a negative adduction drop test. And they're going to describe this as changing the position of the ilium relative to the sacrum. So if we started in this position, they're alleging that we're literally able to bring that innominate bone back into this position. That's going to change the ability of the femur to adduct. And when the femur can adduct, that means that the person is in neutral. Now, neutral in PRI land is going to be the ability to shift over the left and right sides of the body, right? And again, the proposed mechanism here by which this works is that we're going to inhibit all those overactive muscles in the left AIC chain. And then when we do so, we're able to get those innominate bones moving, which is going to improve our ability to adduct, right? So now it's important to understand, and maybe you've got this so far, that the way that they're actually testing for this is they use a test-retest approach. So they're going to lay that person down on the table. They're going to do this adduction drop test. They're going to expect that that test is going to be positive, right? Because everyone, according to PRI, is a left AIC. Okay, so they're going to expect that almost everyone is going to be positive, especially on the left. Okay, and this is universal based on underlying asymmetry, according to them, right? So they expect it to be positive based on their model. Then they're going to use a repositioning drill, which is going to help someone shift into their left side, both from a mechanical and neurological standpoint. And then following this, they're going to do a retest. And they're going to deem that intervention effective if on retest, they're able to go to this adduction drop and that person has a negative result. Now, again, their definition of a negative test is when the knee actually touches the table, okay? Now, in PRI, achieving neutrality is an essential component of the program. In fact, you'll hear PRI faculty claim that if you're not neutral and you try to do retraining on a pelvis that's not neutral, then it could actually be dangerous and contribute to pathology. So you might be wondering at this point, if we assume that this PRI thing is valid, that it has some validity to it maybe, then what happens if you can't get neutral? Now, if you can't get neutral, PRI recommends other approaches. These approaches often include interdisciplinary integration, which gets very involved and very expensive and comes with no promises, right? So we're talking about foot orthotics, custom made, special prescription glasses, mouth splints, or even invasive orthodontic procedures. Now, again, these approaches are expensive and can run patients often 4 to 5 figures. And the theory here is that these interventions are going to help relax that overactive left AIC chain by providing sensory references. So, for example, if it's a mouth splint, that's going to allow someone to get some more occlusion or contact between the teeth, especially these left molars. And when they're able to do so, they're going to be able to shift their body more to the left. And when they feel safe moving to the left, they're going to inhibit that left AIC. And when that happens, we're going to expect that this adductor drop test should be negative. Okay, so from this point on, we're going to say adductor drop and Ober's pretty much interchangeably. Okay, so what if this Ober's test, which is what the test really is, isn't a reliable test when it comes to pelvic asymmetry? What if the Ober's test isn't a valid measure of pelvic asymmetry at all? And what if testing mistakes are very common in this test, right? And what if our assumptions of what should happen actually predispose us to more human error, right? What if the criteria of these tests set by PRI actually impose an impossible standard that can't be met when we perform the test properly? This all has very significant conclusions when we consider that if this is true, this would undermine the entire PRI framework. But secondly, if this is true, it's also going to push a lot of people towards this expensive interdisciplinary work that they might not need, right? So I'm sure that some people are using these tests in a responsible way. I've seen some very good examples, but among PRI's loudest online voices, we're seeing a lot of testing errors. And when one puts out the propagation of this message as an absolute certainty, then a lot of vulnerable patients are going to be affected and not in a good way. So to really answer these questions of, is this test valid, reliable, and should we use it to identify and intervene when it comes to pelvic asymmetry, first we have to actually go through the test. All right, so a little history here. The test was first described in a 1935 article that was published by Frank Ober. Now, there was some initial criticism by Henry Kendall, and after that, Ober changed his description slightly in his 1937 paper. Okay? And there were a few important details that we'll cover after we talk about the test. Now, in the 1937 article, Ober called this the abduction test. And here is the description directly from that text. The patient is going to lie on their side on a table. The shoulder and the pelvis should be perpendicular to the table. The leg on which the pelvis is lying is flexed at the knee and hip, and it should be done so to keep the lumbar curve flattened, right? So in neutral lumbar position. If the patient is on their left side, the examiner places their left hand over the patient's hip in the region of the trochanter, right here, okay, to steady him. The right hip or right leg is flexed to a right angle at the knee and grasps just below the knee with the examiner's right hand. The leg and ankle being allowed to extend backwards under his forearm and elbow. The right thigh is abducted widely, then hyperextended in the abducted position. The lower part of the leg being kept level and care being taken to keep the hip joint in a neutral position as far as rotation is concerned. So that means as we're bringing it back, we need the foot and the knee to be level, and then we're going to make sure that we're moving directly in the frontal plane. Then from here, the examiner slides his right hand backward along the leg until it grasps the ankle lightly, but with enough tension to keep the hip from flexing. The thigh is allowed to drop toward the table in this plane. Caution, do not bear down on the leg. If the fascia lata and iliotibial band are tight, the leg will remain more or less permanently abducted. If the hip is allowed to flex or internally rotate, the iliotibial band becomes relaxed and the leg falls from its own weight. And lastly, the same procedure for the opposite side is followed in every case. All right, a little sip of caffeinated Diet Coke here. All right, so according to Ober, what is a negative test? I'm going to include an image here and the testing criteria from Kendall. Now, a note on the definition of a negative test. Quote, with the knee maintained at a right angle, the thigh drops slightly below horizontal. Okay, so we're going to notice something here important in the description. A positive test is just the ability to move past the horizontal line. It's definitely not all the way down to the table. Now, there's also a few notes in here about what to avoid during the test, and here they are. First, the examiner must avoid internal rotation and flexion of the leg. The reason is that this allows the pelvis to drop more easily than keeping it in the same frontal plane. Second, one must not bear down on the leg. If the test is actually negative, the leg should fall on its own. And last, the test defines negative as slightly below horizontal, not knee touching the table. And in Kendall, she makes a few points about the history of the test. She says that in Ober's original description, he states that in a negative test, the thigh will adduct beyond the median line. Now, what does he mean by median line? Kendall goes on to make the point that this was actually before the release of the second paper, and that due to the criticism of Kendall, the second paper added the detail of avoiding internal rotation and flexion. And when you avoid adduction and flexion, a normal amount of adduction purely in this side-to-side plane with the pelvis in neutral is roughly 10 degrees. If a normal test is moving 10 degrees towards the table past the horizontal line, that's a lot different than touching the table. All right, so at this point, we've got a real problem on our hands, which is that we're lacking a clear definition of what a normal test is. Is a negative test when we move 10 degrees past this horizontal line, past median line, whatever that means, or when knee is touching the table? And to find this out, we can actually look at studies that have performed the Ober's test under lab conditions. Now, we're going to go through just a few here, but I have a much more descriptive and comprehensive outline in the blog post that is associated with that podcast. So if you want to dive into those numbers, go ahead and check those out. Now, in one study that used an inclinometer, the average range of motion of a negative test was about 25 degrees. And in that study, there were 600 tested limbs, 432 were subjectively assessed as negative, again, with about a 25 degree measurement, whereas the 168 that were tested as positive had an average of about 16 degrees of measurement, right? So now, again, these are averages, and we're talking about a study where the examiners were having to agree on a subjective definition of what's positive and negative. So to them, going down 25 degrees was negative, and anything around 16 degrees was positive. So obviously, they're not defining it exactly as Ober did to begin with, but they're nowhere near knee touching the table. Now, if you're thinking about this 25 degrees, though, you might think, depending on the actual length of the limb and the width of the pelvis, the distance of the pelvis away from the testing surface, there is a possibility that the knee could be touching the table. So maybe it is correct to say that the knee should touch the table. But when you go and you look at this study and how they actually set up the actual test, you're going to see how their setup might have influenced these numbers towards being a little bit bigger. And when we look at how they perform the test, the support leg is in near full extension. So when we're in near full extension with the support leg, the pelvis can move into anterior tilt more easily. And so in the actual study, it does appear as though there's a little bit of anterior tilt in the pelvis. And what that allows is, if the femur is kept here just in sort of a midline, is that we're going to be able to access some degree of flexion and internal rotation, which is going to increase the ability to adduct with greater ease. In fact, we have a paper that looks at this exact aspect of the test, and they found that as you flex the support leg, the amount of adduction in the tested leg actually decreases. And so this means when you're doing the test, you must account for the position of the bottom leg. Oof, so we've got a lot to think about so far. We got to make sure that this leg is in the frontal plane, the pelvis is neutral, and the bottom leg is consistently placed. Now, I don't know about you, but that's a lot of variables to account for. And if we even go all the way with this and we think about what would happen if we brought the pelvis into a posterior position, we're not going to expect much adduction at all. So if we're too far tucked back past a neutral in the sagittal plane, then we're also going to start to limit adduction as well. Now, if you haven't figured it out yet, this test also has two main issues that are going to raise further questions. The first being that the assessment is subjective. This means that we deem it positive or negative based on our own criteria. And the second is just the mechanics of the test itself, which is the need to stabilize and position multiple segments at once. Now, to find a more objective criteria for what we should expect in terms of the adduction angle, cadaver studies might provide us with a little bit of a cue. In the 2016 paper, An Anatomic Investigation of the Ober's Test, the average for the Ober's tests were about minus 2.9 degrees to 6.5 degrees. And in this study, the authors were removing various structures to determine each's influence on motion. And although it was a cadaver study, we should caveat this all with saying that, the authors were likely able to stabilize the body to a greater extent than you might in other laboratory conditions. Because as it turns out, in every study, stabilizing the body is a concern. And this concern is exactly why some consider the reliability of the Ober's test to be poor. Now, in a few minutes, we're going to go through all the different examples of all the testing errors. I'm going to demo these on a skeleton model, or I'll at least link that video with all the different testing errors. And then we're going to get some real-world examples from those who actually use these tests. But before we do this, we need to answer a big question. Is the Ober's test a valid test of pelvic asymmetry? And again, when we say pelvic asymmetry, we mean when the bones of the pelvis differ in alignment or shape between sides. And when we're discussing PRI, we mean that the left innominate bone is forward relative to the sacrum. And again, to be more specific, this is inlet external rotation, flexion, and abduction. And PRI alleges that this innominate position is what restricts movement at the femur. In fact, I've got my PRI manual here, and they say that the limitation can occur due to a few factors. But the consistent claim is that this position of the left innominate increases impingement of the proximal femur on the rim of the inferior medial acetabulum and/or labrum. But can the Ober's or adduction drop test actually determine this position? Now, again, when you look at the validity of the test, there's a few levels to this. On one level, there's just face validity. And sort of, this is like the vibe check of validity. Right? Does it seem like this is what this actually measures? Does it seem plausible that that might limit motion? And I'd say yeah, maybe. But the next level, which is much more strict in terms of what we have to meet for requirements, is construct validity. And this is going to involve proving that this test actually measures what we say it measures. And to do this, we have to compare it against a gold standard. Now, gold standard just simply means the current best test available to determine a particular condition. And in the case of pelvic asymmetry, right now the gold standard is CT scan with 3D reconstruction. Now, at the moment, there are no tests that directly compare the Ober's test to the CT when it comes to identifying pelvic asymmetry. But I did look into a few articles to see if the authors found a forward left innominate. Remember, according to PRI, the Ober's test is positive on the left due to a forward left innominate. And if this were true, we'd see this trend playing out in CT studies as well. But upon review, it appears that the position differs across individuals and across samples. And in one paper, it appears as though the pattern described is actually the opposite of the left AIC pelvis. So with this said, we really can't say that the Ober's or adduction drop test is a valid measure of pelvic asymmetry. So if the Ober's is not a valid measure of pelvic asymmetry, how could your PT actually assess pelvic asymmetry? And I'd really be remiss at this point not to flesh out the concept of PT tests to identify asymmetry in general. When you're earning your PT degree, you're going to learn how to assess the SI joint mainly by palpation, or putting your hands on bony landmarks and seeing if you perceive motion around the SI joint. But given the fact that there's only 2 to 3 degrees of motion around the SI joint, even the validity or reliability of these measures comes into question. And for this reason, it's understandable to want to perform hip range of motion tests instead of these palpation-based SI joint tests. After all, these are very standardized and they're already part of every PT exam. So can we infer pelvic asymmetry, intrapelvic asymmetry from these? We'd be more reliable if we could, right? Well, not so fast, because we're assessing the hip joint, and there's a lot of room for error in our measurement when it comes to the SI joint and assumptions that we're making based on those hip measurements. For example, let's say you have a tight hip capsule. That might cause a restriction in range of motion during one of these hip tests. And if we can't assume that this reduction is actually going to reflect anything consistent at the SI joint, then it's probably not a good test. In fact, reduced hip range of motion could actually correlate with increased motion at the SI joint, not decreased. And so for this reason, we must be cautious to say anything about the SI joint just based on hip tests alone. And if we are, we should have professional training that allows us to assess for hip pathology. So if you're working with a personal trainer or a massage therapist, they're not trained in being able to manually assess for pathology of the hip like an orthopedic physician or a skilled physical therapist. For example, let's say that you have a labral tear in your hip, which can limit range of motion. If your personal trainer or massage therapist doesn't have the skills to assess for that labral tear, they may assume that this means something about asymmetry in the pelvis, and it actually doesn't. Now, as we're going to see in a second, personal trainers and massage therapists are among the loudest in this PRI space, demoing these tests and then telling people that it means something definitive about pelvic asymmetry. Now, with all this said, good PT exams are comprehensive. We take a lot of measurements, a good history, and understand the client goals. With this big picture in mind, we then co-create a plan and establish a therapeutic alliance. Now, in my view, basing any plan off a limited number of table tests increases the chances of poor outcomes. The less tests you use, the higher those chances are. And it's with this in mind that we're going to go through the following examples, and in doing so, highlight some of the common errors in using the Ober's test. Now, as we go along, I'm going to give some commentary as well about the test and some of the points that we've discussed so far. And one last thing is that if you want to see a comprehensive analysis of all these possible errors, go ahead and read my blog. I literally have videos on every single error you could possibly make from different views. It's going to be great. So if you really want to dive in deep and you want to use this test, you need to go check out those videos. All right, so let's now dive into the examples. All right, so mistake number one is simply just using one test. The mistake with using one test to determine position is that it doesn't account for outliers. In Kendall, Ober states that most with a positive test have increased lordosis of the lumbar spine, but some have reduced lordosis. And this means that for some, the pelvis biases more posterior tilt, and we can still have a positive test. But in this case, the positive test is for a different reason. Now, this should make sense given what we talked about earlier about the bottom leg position, right? As that bottom leg flexes, the pelvis, especially if we're tight back here in the back of the hip, could actually tuck under into a posterior tilt. That posterior tilt is going to make it harder to extend the top leg, and the less we can extend here, usually the less we can adduct. But again, this isn't because we have a forward pelvis in this case, it's actually because we have a backward pelvis. So if you do this test, you must have at least one other test to rule out the possibility that the pelvis is too far back or that there's some other factor at play. Now, in this clip, we're going to see what Neil Hallinan has to say about what this test indicates.
Which means that right pelvis is forward, which blocks the ability to adduct.
Okay, so he's saying that because the Ober's test is positive, it means the pelvis is forward, and the only reason for this inability to adduct is that the pelvis is forward. Now we're going to do the left side.
On the left. If the right side is forward, the left side is definitely going to be forward because it's asymmetry.
All right, so he just says that if the right side is forward, the left side is definitely going to be forward. So there's an assumption about what's going on and about what tests we should see. So there's a lot of bias here in this exam.
And you're going to see that he can now pass all of his tests. So he is now neutral.
Okay, and it should be noted here that we're seeing a pretest, and then coming here, we're seeing a retest. And actually, there's a number of testing errors here that we're going to go over in a second. And I would say that based on the way he's doing this test here, we actually can't tell if there's a change between pre and post test, but we definitely also can't assume that we know what's going on just based on this one test. Now, what he's saying here is that pre-test being positive and the retest being negative means that that person went from an innominate bone position of this to an innominate bone position of this. Whether that's even possible is neither here nor there, because these tests are actually not being done in a comparable way, and it's only one test, and we know that there are outliers here. All right, now mistake number 2 is allowing flexion and or internal rotation of the tested leg. And once again, this would make it easier to adduct, resulting in a false negative. In PRI, they say that if you can't extend, you can't adduct. And again, this is true to an extent, but you're gonna find the more that you bring the leg back into extension, the less adduction you're gonna get overall, right? And you can try this for yourself. Just simply lay on your side with the bottom leg a little bit flexed. You're gonna bring that top leg back a bit shy of full extension, let it drop down. You'll notice how much motion there is, then do it again, bring it all the way back into full extension. And as you allow it to drop down, you're usually going to experience a pretty significant reduction in the amount of motion. So let's go ahead and check out this second clip. This is of Ron Haruska, the founder of PRI, performing this test. All right, so here on this side, we're gonna see a relatively well-executed test. We see adequate pelvic stabilization. The leg is brought all the way back into extension. Foot and knee are in alignment with each other such that they're the same distance from the table, which means the limb is not biased towards internal or external rotation. And this is a good example of a positive test. Now we're gonna fast forward a little bit and we're gonna look at the opposite side. And here we're gonna see the very common testing error of allowing that leg to move into internal rotation. So we'll see that initially as he pulls back on the leg, the entire pelvis and lumbar spine actually orients forward in space. So there's increased lordosis and an anterior tilt, and that is going to position the limb into flexion and internal rotation, right? Because anterior pelvic tilt is the same from a pelvis on leg perspective as flexion of the femur relative to the pelvis is. It's the same position, right? So we've already picked up more flexion, and with flexion, we're gonna have increased access to that internal rotation. Now we can actually see that during this test because as Ron really pushes down the leg, which is another mistake, what we see is that the knee actually ends up below the foot. And with the knee below the foot, we know this limb is biasing internal rotation, which once again is gonna increase our ability to adduct the leg and contribute to a false negative test. Now there's a couple of other errors here which we're gonna get into in a second, but as you can see, when we allow flexion and internal rotation, we increase the ability to adduct. If we didn't do that on our pre-test, then we don't have a comparable pre and post-test, and we can't say anything definitive about pelvic asymmetry or really anything else. Now, mistake number 3 is certainly second to none, and that is inadequate pelvic stabilization. When we're gonna look at all these errors, this one is the most prevalent, and you're gonna see it in most cases where there is a mistake in testing. We're gonna show just one clip here, but if you want to see more examples of this, again, go check out the blog. Now, just a note here, this side-lying test in this position is really one of my least favorite. And the reason is that it's really the most prone to pelvic positions. The patient in the side-lying position is gonna be resting on their bottom hip. And the shape of the pelvis overall is gonna be more narrow front to back than it is side to side. So in side lying, it's very easy for the pelvis to rotate in this transverse plane or in the frontal plane, both of which are gonna decrease the accuracy of the test. So if we do want to use side lying, we really need to take special care to stabilize that pelvis at every point during the test. And many of the studies that look at reliability actually have extra clinicians or external stabilization to make sure that that pelvis doesn't move as they perform the actual measures. And of course, this is not actually realistic from the standpoint of doing that in the clinic where you're usually going to have just one person, right? So in the actual testing errors, we're usually going to see that the pelvis moves in the frontal plane with the leg. So what that does is it increases abduction, which then allows room for the leg to move into adduction, once again, increasing the likelihood of a false negative. All right, so now we're gonna go through a couple of examples here we have some clips of Alina performing the adduction drop test, and we're going to see a frontal plane shift in almost every single example. So we're coming back into extension, and as we drop, that's the pre-test, doesn't drop. Now on the retest, it appears as though the knee drops, but actually what we're seeing is a significant movement of the pelvis and above the pelvis in the lumbar spine in that same direction. So we have a drop of the pelvis that makes it appear as though the knee is dropping further, but it's actually just the pelvis dropping, allowing some abduction initially to make space for more adduction, again, increasing the likelihood of a negative test. And you'll see that when we lower the leg in this kind of a position, we have inadequate pelvic stabilization. And we'll see that again in basically all these examples. So here we have the pretest. Again, no pelvic motion. Then we roll it to the retest. And here you're going to see that whole pelvis drop down as that knee is lowered to the table. Pretty obvious motion here. Same thing here, pretest. Pelvis doesn't move. Retest, pretty obvious drop. Pretest, pelvis doesn't move. And then on the retest, yeah, we're going to see the retest here in a second. Then on the retest, we see the entire lumbar spine and pelvis going along for the ride. And of course, this is so prevalent. We also see this with Ron in that other clip that we looked at. We see the pelvis pretty significantly changing position between when the limb was brought back and when the limb was dropped. You can see that drop right away. And if you want to see more examples of this, go ahead and check out the blog. All right, so moving on to mistake number 4, this is inconsistent support leg position. So as we mentioned before, the position of the bottom leg is going to impact the test. If we bring the bottom leg up into more flexion, we're going to tend to see less adduction. And the likely mechanism here is that if we tuck that pelvis more posteriorly, then as we bring the top leg into extension, we kind of reach end range sooner. If we're limited in how far we can extend, usually we'll be limited in how far we can adduct. So again, the big takeaway here is that if you are going to use this test, you need to standardize that bottom limb test position, especially within the same subject. So now let's take a look here. We're going to see inconsistent support leg position here. And this is pretty obvious. All right, so let's look at this clip. Here we're going to see the alleged negative test. We have a few other testing errors there, but what we want to note is the distance of the knee from the hip. The knee being further away from the hip indicates that we have less knee and hip flexion, which means that the pelvis would be more permitted to move towards an anterior tilt as we extend the top leg. That's going to increase the amount of adduction available to us on the test. Now we're going to look at the alleged positive test. As we come back here, we're going to notice the knee is closer to the hip, indicating that we have more knee and hip flexion, which again will bias the pelvis more posterior, or at least limit its ability to move anterior as we extend that top leg, which will reduce the ability of that top leg to adduct and be more likely to result in a positive test. So let's see. Yes, here we have a positive test. Let's watch once again. Here, both together. We can see a number of other testing errors here as well that indicate that this bottom test should have been stopped earlier. But again, we'll notice that the knee is further up in the top in the positive condition and lower down in the negative condition. So I ended up putting some lines on here just to make this easier to see. We have a couple of other errors here. The pelvis is obviously dropping in the frontal plane in this top negative test. We have the knee on the bottom leg rising up more, which indicates that the pelvis is moving more during that test. But what we want to highlight in this clip is that we have the knee and the hip further apart, so less flexion in the negative condition versus the positive condition. And once again, this difference can influence the pelvis and thus makes these two tests incomparable. All right, now mistake number 5 is pushing the leg down. You'll remember earlier that we said in the original text, Ober himself cautions against pushing the leg down while we perform the test. We want to maintain the leg in the frontal plane and control it, but we don't want to push it down. We simply want to let the leg drop. Now, we're going to go back to the clip that we saw of Ron from earlier, and we're going to observe a good example of pushing the leg down. All right, so here we're going to see in the pre-test, Ron attempts to push the leg down, but can't. And then in the other test, which is supposed to show that the right side tends to be negative, we're actually going to see that Ron pushes that leg down rather aggressively. And what happens as that occurs, if you pay attention to the pelvis, is we're going to have a significant frontal plane drop, which again positions the pelvis towards a position of abduction, which then opens up space for the femur to move into adduction. So once again, this pushing of the leg down will just increase the probability that the leg is going to move out of the frontal plane or that the pelvis is going to move excessively in the frontal plane, once again, giving the appearance of a negative test, but not being a comparable test whatsoever. All right, now on to the last mistake, number 6. This mistake is inconsistent lower leg position. Now, we haven't mentioned this yet, but there's actually 2 forms of Ober's test. There's the Ober's test and the modified Ober's test. And the frustrating part is that if you look up the Ober's test, you're often going to see the naming convention sometimes switched, but the Ober's test, the straight up Ober's test, is where the knee is flexed to 90 degrees, and the modified version is where the leg is straight, so knee fully extended. Now, there have been some studies that look at the difference in the overall motion with the Ober's and the modified Ober's position, and knee extension or less knee flexion tends to increase the amount of adduction that we're going to see on the test. So this means that with the knee extended, the measurement values are going to tend to be greater. So if you see someone perform a pre and a post test, but the post test has more knee extension than the pre-test, then you're not getting good data and you're likely to get a false negative. So let's take a look. All right, so in this clip of Connor, we're going to see the original test, and we'll note here that the knee of the tested limb is in about 90 degrees of flexion. And it looks like the leg cannot adduct, thus reflecting a positive test. Same on both sides. Now we're going to see here in the retest, though, that we have the knee much less than 90 degrees flexed, and the knee itself is actually positioned much closer to extension than flexion. Now we can ignore the lack of pelvic stabilization in the frontal plane and just look here at the knee, knowing what we said a second ago about the Ober's versus modified Ober's and the values we can expect to see. It makes sense why we're seeing this increase on the retest. We're going to see that on that side as well as on that side. So once again, if we have a different amount of knee flexion on pre and post test, we can't actually make any conclusions about what that test is telling us. All right, so by this part of the podcast, you should know what the Ober's test is, the history, why we think that it might not be valid or reliable for assessing asymmetry, and if you want to dive even deeper, go out and check out the blog. But it's at this point I'm going to give my closing remarks. Many clinicians use the Ober's test, but as you see, the test has a lot of problems. And like many other PT tests, it doesn't really tell you a whole lot on its own. And like other PT tests, there's a lot of nuances to performing it. And so while this one test alone probably can't tell you anything about pelvic asymmetry, it can be part of a greater battery of tests. One should combine this test, or really any other test, with several other tests of range of motion, strength, as well as functional measures. And as important in this discussion is understanding the nuances of testing. In this video, you saw professionals and non-professionals alike making pretty blatant testing errors. Now, in my view, there are likely 2 reasons for this. The first is motivation to get an outcome, and I believe that this motivation is twofold as well. The first aspect is a desire to prove that your conceptual model is correct. If a positive outcome validates your model, then it's human nature to want to see that outcome. And the second aspect of this motivation is a desire to get your client an outcome and to feel competent. If your client perceives that they're getting a change, then they're likely to value your services. But I believe that one must guard against these natural human tendencies in favor of increasing accuracy. If these are the way that you test, you're going to undermine your ability to improve your clinical skills over time. None of the information that you gather when you're performing these tests in incomparable ways actually increases precision of your assessment or your interventions. Now, the second reason for these testing errors is in the training of the user. In my doctoral program, we learn these tests inside and out. And any one of these errors would have resulted in points deducted on our practical exams. The instructors would have corrected us, and after the practical exam, they would have shown us what we did wrong. And this is the advantage of investing in the required professional academic training. You get that one-on-one, hands-on instruction for many hours, and you're doing it alongside students that are also being held to the same standard. This is incomparable to the weekend courses where many non-professionals learn these tests. And I believe this is why personal trainers and massage therapists should not rely on table tests in general. It's fine for these folks to do them, but they shouldn't use them in a way to prescribe interventions. Instead, these measures might just be a good checkpoint, but without this higher-level skilled interpretation. And last but not least, educational organizations like PRI should restrict their student pool. In my view, it's inappropriate to teach these concepts to non-professionals. They lack the prerequisite experience and skills to use these tests in a responsible manner. In my view, emboldening non-professionals to perform physical therapy examinations undermines patient outcomes. It also has unintended negative secondary consequences for the physical therapy profession. This only increases confusion about the difference between a trainer and a physical therapist. All right, so if you made it this far, here's the recap. The Ober's test is not valid for identifying pelvic asymmetry. It is a complex test that must be a small part of a greater evaluation, and only those with a deep understanding of the test should use it. Now, if you are a trainer or a coach who wants to understand how to use table tests responsibly, I've got you covered. Apply for my mentorship and learn how to design training programs with applied biomechanics. All right, that does it for this episode. As always, thanks so much for watching, and until next time, peace.